About 9, 10 o'clock last night, Lori, Dr. Schoenberger, and I were on the phone with Ryan Maddox, who was, I think, probably hour 14 in Atlanta airport. And we were thinking about what would happen if his third option canceled. So we had, thankfully, with the help of Chris and the crew here, we were going to do it virtually if that happened. But what struck me is Ryan was very adamant. He wanted to be here in person. He says the whole conference is about being here in person. I want to be there, and then, of course, there's moving around tables. It's made more exceptional in that he actually is leaving tonight at 6. So I'm not even here a full day. So, but I think it really, speaks to the commitment of people like Ryan and others here. So, Ryan, thank you for that. So it's my pleasure to introduce Dr. Ryan Maddox. He's an epidemiologist from CDC and the Prion Public Health Office. I think you've been here more consecutive years than I have. And he always gives a great explanation of epidemiology here in the country and always usually focuses on some specific thing. So Ryan, thank you very much.
Thank you, Brian. Thank you to the organizers, and thanks for switching the schedule around. Brian mentioned that I'm flying out tonight. Usually I speak on Sundays. I'm excited to be speaking to you this morning because I think that could lead to some excellent questions during the roundtable sessions as well, and chance to further discuss what I'm going to very quickly present this morning. So thank you for that. And just to start out, a little bit about what CDC is, what it does. Some of you, of course, are already familiar, but we're under the Department of Health and Human Services. This is the nation's leading public health agency. We do not have any responsibility over global IT infrastructure. Can't blame that on us, but what we do is control disease outbreaks, look at food and water, make sure they're safe, help people avoid leading causes of death, also try to reduce threats to the nation's health. We're all over the place. There are a lot of us. Most of us are based in Atlanta, where I work, but we are in other states and other countries as well. Our particular center within the Centers for Disease Control is the National Center for Emerging and Zoonotic Infectious Diseases. Within that, we're in the division of high consequence pathogens and pathology. And that's obviously a very fitting name. I can't think of anything more high consequence than a disease that's 100% fatal, and hopefully not for long, but at this point, unfortunately, that is the situation. So very high consequence. Within this division, we're a very small office called the Prion and Public Health Office. And a few of us from that office are here. Some of you may have already talked to Dr. Larry Schoenberger in the first picture. Let's see, am I doing this right? Marissa Person is one of our statisticians. Dana Haberling was here earlier but had to fly out last night after many delays. And Dr. Joe Abrams, also an epidemiologist in our group. What do we do? Our main task, our main mission is surveillance for human prion disease. We also follow animal prion diseases. We're concerned about animal prion diseases. I'll talk about some of that later. But that's with the focus or the perspective of human disease when we look at that. We try to monitor disease in the population, looking at disease rates, changes in the epidemiology over time, and trying to detect novel forms of prion disease. There's a lot we don't know, and so we try to gather and learn about the disease as much as possible. How do we do that? Well, we have two main ways of doing this. One is through death certificate analyses, using data from death certificates. As you all are aware, as I mentioned earlier, these diseases are 100% fatal. And so death certificates are a convenient and cost-effective way of tracking cases of the disease each year. And Marissa Person in our group is one of our main links to the National Center for Health Statistics, which provides that information. And she's very adept at doing analyses on these data. CJD coding does not have to be on the death certificate if CJD is written on it, or GSS, or prion disease, or any number of misspellings. It is picked up through a literal text search on those death certificates. So we do capture a lot of the cases through these death certificate data. Now, we also partner and help fund the National Prion Disease Pathology Surveillance Center, which, of course, as you're aware, does all sorts of diagnostic testing. We can use those results to match with the death certificates and add or subtract cases from that based on the results of those tests. And just a quick snapshot of 2003 to 2021. Why do we start with 2023? There were some changes made in how the National Center for Health Statistics compiled the death certificate data that were finally fully implemented in 2003. So it's a good start point when we look back. But we have been looking at death certificate data since 1979. Why is 2021 the endpoint? That's the last year of complete data that we have. Unfortunately, we run a couple years behind in getting these data. It takes a while for NCHS to compile and clean these data. And if you want more information, Marissa will be happy to talk to you later, I'm sure, about the last few years. There have been some delays. NCHS has been implementing new changes that have kind of slowed the process a little as well. So unfortunately, we don't have the 2022 data yet. But through 2021, combined, we have an annual age-adjusted incidence of 1.2 cases per million. Among males, it was a little higher at 1.3. Among females, 1.2. But of course, among the older population, greater than or equal to 65 years of age, that goes up to 6.1 cases per million per year. So obviously, it's more common in that older age group. Just looking at the most recent year of data alone, 2021, there were 588 cases that we identified through that matched analyses of NCHS death certificate data and the Prion Center data, very close to what we saw the year before in 2020. There's 1.3 per million, the rate we came up with. But another way of looking at this is that there was one CJD death for approximately every 5,900 deaths overall in the United States. So looking at it from that perspective, it certainly sounds more common than the 1 per million statistic that you hear so often. We did find definite or highly probable matches for at least 82% of cases when we looked at the death certificate data and tried to match it to the Prion Center test result data. And I think that just shows what a great job they're doing in terms of awareness, in terms of people being aware of the services they provide and using those services. And I say 82%, it's in reality much higher than that. We can't match all the cases, especially if we don't have a date of death, for example, or other missing identifiers that we would need to be confident about a match. And just to, again, look at the 2021 data, based on that matching that we did, we removed 10 cases from the death certificate data that actually had a negative autopsy from the Prion Center. And so they weren't true cases, at least in our opinion. But we did also add 42 autopsy-confirmed cases that the Prion Center did the testing for that were not in the death certificate data. As you guys are aware, death certificate data is not 100%. Unfortunately, CJD, any variation of that doesn't always end up on the death certificate. So we are able to capture a lot of these cases by looking at the Prion Center data. This is just a very general graph of what's been going on since 2003. The increase at a glance may look alarming. However, we have an aging population in this country. So more cases each year, since this is a disease of primarily the older population, is expected. Not only that, there have been improvements in case ascertainment, detection with RT quick testing, with improvements in MRI, and also just general awareness over the last 2 decades. So this increase to me does not suggest any kind of exposure or anything else unusual going on other than the things that I mentioned. RT quick test is obviously a great test. It's a game changer in terms of identifying and diagnosing these cases prior to death. It strongly indicates prion disease when it's positive. However, autopsy is still the gold standard, and so we do still encourage autopsy, which also provides additional information on a case. Now, not all these RT-QuIC tests end up with an autopsy being performed. And so sometimes the Prion Center doesn't have a date of death for these cases, or they're lost to follow-up. And we've predicted that at least in 2020, we might be missing 20% or more cases based on that. And so we have a project in process where we are seeking to identify the dates of death of these RT-QuIC positive cases, looking at the National Death Index and adding them to the appropriate years to come up with an even more accurate estimate of the national prion disease incidence. And our suspicion is that may bump that up from 1.2, 1.3 to maybe 1.4, 1.5. I don't see it going up to 2.5, 5 per million or something like that, but it's certainly going to increase that rate some. We also focus on young cases, and I define young as less than 30 years of age. Most of these cases have a genetic mutation or other risk factor, for example, human growth hormone or variant CJD. And so we like to focus on these cases because of that fact. To give you an idea about how rare these cases are, only 19 cases identified in the period 2003 to 2021, which comes out to 8 cases per billion per year. So extremely rare. Only 7 of those were sporadic. So like I said, most of these have some other explanation, usually familial, but also 2 cases were variant CJD. There was 1 iatrogenic CJD over that time period from dura mater. Usually this comes out to about 1 or less cases per year. There were 3 cases in 2019, which was very unusual, but we were back to 1 case in 2020, 2021, and actually 1 in 2022 that we're looking into, although it says 0 there. Like I said, we still consider autopsy the gold standard. Neuropathology is so important because it can be a sentinel for unique and possibly emerging prion disease cases. That was the case with variant CJD, where the brain tissue analyses of these cases looked different than sporadic CJD, for example. But a positive RT-QuIC in the context of a neuropsychiatric illness is strongly indicative of prion disease, and that's why we're evaluating those cases with no date of death, because we feel confident that they are most likely true prion disease cases. So I mentioned that we use multiple cause of death data, the death certificate data, and also the Prion Center data. We also rely on public health departments, medical personnel, family members, the public, and the media for awareness of cases. And we do try to capture the majority of cases in our surveillance, but we do not capture every single case. I certainly can never make that claim. But if a case was seen at the Prion Center, we do collaborate, obviously, very closely with them. We are aware of that case. If the diagnosis does not end up on the death certificate, unfortunately, the autopsy results come later than the death certificate. They can be amended, but the process varies from state to state. I know some of you have been through that process, and some states make it more difficult than others, unfortunately. The disease is reportable to some degree in most states. The bottom line is a misdiagnosed case is still a misdiagnosed case. So making it reportable still doesn't identify cases that no one identifies. But it can be helpful if the state has a mechanism in place to follow up, and it may facilitate accomplishment of goals that we outlined through the Council of State and Territorial Epidemiologists to conduct certain surveillance actions and goals. We provide funding to strategic states for enhanced surveillance activities. Rachel Straver from Texas is an example of that, where we feel Texas is very strategic given the size of the state, its occurrence of a variant CJD case, BSE, CWD. Texas has it all. So we consider them a key resource in our surveillance. We do occasionally become aware of clusters. These are often brought to our attention from family members or the media. The good news is when we take a closer look, these clusters typically disappear. And when I say disappear, it means that what's initially reported to us as 3 CJD cases in a small town turns out to be 2 non-CJD cases and 1 CJD case. Or one of those cases just moved there a few months ago. Or 2 of them had a genetic form of disease in the same family. Or 3 cases was expected. The particular hospital serves a tri-state area, and the denominator there would be so large that 3 cases in any given time period would not be unusual. So just to say that these situations do happen, but upon closer investigation, we're usually very much reassured about the situation. And we rely on our state and local health department partners to look into these situations. Variant CJD, 233 cases worldwide. That's the same as I shared last year, and hopefully it's going to stay that way. It's been on the decline. In fact, 3 of the last 4 cases that have been reported have been linked to an occupational exposure rather than consumption of a bovine spongiform encephalopathy infected cow. So it seems like these laboratory exposures or occupational exposures are the bigger risk now, which is certainly different than the mid-90s and early 2000s where the BSE outbreak was such a concern. And again, hopefully this will continue to be the trend going forward where we're not seeing new cases each year. 4 of those cases have been in this country. We believe that they were all exposed elsewhere, but convention says that where the case was diagnosed is the country that it is attributed to. A little on tissue and organ donation. FDA guidance says that people diagnosed with prion disease cannot donate things such as human cells, tissue, cornea, skin, things like that, history in a blood relative. It is not regulated as far as organ donation, such as liver and kidney, but at the same time, there's a risk-benefit analysis that might be performed by medical staff to determine what degree of risk they're comfortable with using certain organs. About 2 years ago, the guidance was updated, which removed the donor deferral for geographic risk of BSE exposure. And that was a big deal. For many years, if you were in the UK or parts of Europe for different amounts of time, you were excluded or deferred from donating blood in this country. And that was very upsetting to a lot of people that wanted to donate and felt like their risk was minimal and really wanted to contribute in that way. And at the time, I think the deferral was appropriate. There was a lot that was unknown. But they do have the recommendations updated now, and people may, if they meet other eligibility requirements, they may be able to donate now. So that was a big change a couple of years ago. However, if you've been diagnosed with prion disease, you're still ineligible. People who received cadaveric pituitary human growth hormone treatment, still ineligible, as well as Duramatter. Joe Abrams, who's here, published a study a while ago which pretty much showed that 1978 and later recipients of human growth hormone did not have the same risk of CJD as those that received it in the mid-70s and earlier. So you may be asking, why are people who received this product so many years ago still ineligible? And unfortunately, as you heard with Kuru, these prion disease incubation periods are crazy. In fact, in the past year, there was a human growth hormone-associated CJD case. We believe the incubation period was around 50 years. So it can pop up many years later, and that's why they are still ineligible according to the recommendations. Again, I mentioned the blood. It is a disease, fortunately, with CJD, it has not been shown to be transmissible through the blood. That's been looked at through various means. If it is transmitted in that way, it must be a rare event if it happens at all, to quote the UK National CJD Research and Surveillance Unit. On the other hand, variant CJD, and again, that's the prion disease linked to BSE or mad cow disease, has been transmitted through the blood In fact, through asymptomatic donors. Unfortunately, those cases are rare, but it can occur. So there is still some concern about additional secondary spread that could occur through blood and contaminated surgical instruments as far as variant CJD is concerned. Funeral homes, embalming can be safely performed, but we can't force funeral homes to accept a body. That's obviously just the way it is. But we do feel education is important, and I know some people in this room have been involved in those education efforts, and some are more open to revising their policies than others. And we do have information on funeral and crematory practitioners on our website. The bottom line is there are no special interment, entombment, or cremation requirements for patients with CJD, that we believe that cremation and cremated remains can be considered sterile. Talk a little bit about an animal prion disease. I mentioned at the beginning of this talk that we do follow animal prion diseases because there is concerns around that. Chronic wasting disease is a prion disease of cervids, including white-tailed deer, mule deer, elk, moose, and reindeer, kind of the deer equivalent of mad cow disease. And clinical symptoms include things like weight loss and behavioral changes. Like any other prion disease, it's 100% fatal. And unfortunately, it's highly transmissible within cervid populations. And in fact, just recently, we've added California, before that Indiana. We're up to 34 states, 4 Canadian provinces where the disease has been found in free-ranging deer. So it's more likely than not that your state has found it among wild herds. And it's been found in Scandinavian countries as well in the last 10 years, Norway, Finland, and Sweden. It's the map that I show every year. You can see the recent cases identified in 2 counties in California. It's always concerning when this happens where there's nothing around it. And you wonder, is there more in this area? How did it get there? But you can see there's various places just all over the country. It's in the southeast now, originated in Colorado, Wyoming area. And so that area is where it's been found the most because it's been there the longest. So we're up to 474 counties. And likely a lot more. We do have a number of other counties we're trying to confirm that likely have the disease as well. Usually I don't like it when CWD is in the news because it oftentimes is a little bit sensationalistic and there's a lot of damage control that has to be done. And this year was a good example of that. Some of you may have heard about this. In April, there was an abstract published at a conference with a very scary headline. 2 hunters from the same lodge afflicted with sporadic CJD, is chronic wasting disease to blame? Now, that was the title. And the abstract went on to give a little bit more information. What the media and the public did not see was the full poster, where one of the conclusions stated, chronic wasting disease is probably not to blame. And so what translated into the media reports were headlines such as death of 2 hunters in the U.S. raises concerns of zombie deer. And this was all over. That was the USA Today. There were others that were even more scary and really not really based on I think the facts of the situation. It turned out the CDC had actually collaborated with the affected states when this happened 2 years ago and concluded that CWD was probably not an issue. There were many factors to suggest that there was no connection, including the fact that CWD had only been recently identified in those areas. And also the Prion Center, fortunately, had autopsied both cases and found nothing unusual in the brain tissue analyses. And so we were very much reassured, and unfortunately, that did not translate into media reports at the time. However, we do have concerns about CWD transmission to humans. This is something that we're not taking lightly. And the good news is to date, there is no strong epidemiologic evidence for the occurrence of CWD in people. That's our main statement. But as you saw from that map, CWD is in more areas, which means increased opportunities for human exposure. We do have the history of bovine spongiform encephalopathy and animal prion disease transmitting to humans. So it's not to say it can't be done. And there are multiple CWD strains exist with different transmission properties. So just because one strain doesn't transmit doesn't mean perhaps another strain couldn't come along or be passed through a different animal and then cause disease in humans. So there's certainly reasons to continue to follow this and be vigilant regarding this animal prion disease. And we do that in several ways. We have a couple ongoing studies, for example. One is a study that's been going on for years in Wyoming and Colorado. Why there? Because that's where the disease has been the longest. And we follow people who purchase hunting licenses in those states and assess whether that particular group is dying of prion disease at a rate higher than we'd expect in the general population. We also are following up individuals who consume venison from CWD-positive deer in Wisconsin. The beauty of that particular project is that the state of Wisconsin contacts people who submitted their deer for testing, and if there's a positive result, they ask the hunter, did you eat the animal? And if they say yes, then we have their name, and we can track this person over time and see if they happen to die of prion disease. So we have a direct exposure, and so we can have more confidence in a study like that if we do or do not find prion disease. The good news about both of these studies so far is that for Colorado and Wyoming, we have not found a higher than expected rate of prion disease in the hunting population. And with Wisconsin, we found no cases of prion disease among that group of hunters that consumed venison from a positive animal. Now, that's a very small study with small numbers, so certainly more people would be helpful, but also more time. This is an ongoing study that we're going to follow for many years. Okay. I'll wrap up just real quick with considerations about COVID. We've received a lot of questions, particularly over the last couple years, about can COVID cause prion disease? And that's because they got a vaccine and then a few weeks later they were diagnosed with prion disease, or they had COVID and then prion disease happened. But really, it doesn't make sense for several reasons. Prion diseases are characterized by very long incubation periods, typically years. There are no unusual neuropathological features observed at the prion center among cases reported as being vaccine-related. And the number of prion disease cases in the U.S. in 2019, 2020, and 2021 were very similar. Again, I'll show this graph. The last 3 years, pre-COVID, COVID, and more COVID, you can see are very similar in regards to the number of prion disease cases we identified. So it doesn't seem to be a big COVID blip happening, which I find very, very reassuring as well. Final thoughts, these diseases present a very unique diagnostic and public health challenge, but we try to conduct surveillance, investigate cases of interest, and provide advice on prion disease-related issues. We have to collaborate with medical and public health personnel, the Prion Center, and the CJD Foundation, all our partners, and improvements like RT-Quick should really benefit our surveillance efforts, but autopsy remains important as well. You can check out these resources, which I'm sure you're aware of. I would like to point out that the CDC website just went through a major overhaul. We are still tweaking the prion disease pages, but the goal was to make everything simpler, more user-friendly, and hopefully we're on our way to accomplishing that. Thank you very much.
Great presentation. So quick question about your surveillance of CWD in humans like in Wisconsin. So you mentioned hunters and licensed hunters. So what about, so the venison is going to be consumed by family members at all in food banks and things like that. Is that taken into consideration?
Yeah, that's a very good question. In Wisconsin, when the state contacts the hunter, they do ask the question, did you share it with anyone else? Some hunters are more willing to share that information than others. Some are willing to share a first name, or I gave it to my neighbor. We usually don't get name, date of birth, social security number. So we can at least get a name for many, and we can run that name against the Prion Center data and just see if any match comes up. So we do follow them in that way. For the more specific searches with date of birth, that's usually not an option. But it is an important consideration, and we track it the best we can, but obviously it's not that easy to do. Yeah. Yes?
I was wondering, could you talk a little bit about the SIDRAP project that multiple people here are involved in? I think that's kind of an important collaborative effort.
Yes, thanks, Brian. I'm not going to remember what SIDRAP stands for, the Center for Infectious Disease Research and Prevention, maybe? Okay. That's out of the University of Minnesota, run by a man named Dr. Michael Osterholm, who's been a major figure in public health for many years. Organized a collaboration of researchers from really across the research spectrum to look at chronic wasting disease from a variety of perspectives. And Brian mentioned several people in this room are involved. I know Brian and Dr. Schoenberger are chairs of a group that Joe Abrams and I and Rachel Straver are members of that look at chronic wasting disease as it applies to public health and medicine. But there were other groups looking at laboratory diagnostics, things like this. So really, we've looked at these different scenarios and tried to come up with an action plan in the event that there's a transmission event to humans. We've had 5 discussion sessions. These other groups, I think there's 4 other focus groups, have had these sessions as well. The SIDRAP group will then compile a document that should serve as a blueprint should we identify a potential case of CWD transmission to humans. Looking at things like, what will that look like? How are we going to know this is a case? How are we going to prove to others this is a case? What actions are going to be taken? Where did the case come from? Did it come from a deer, or was this from a deer that transmitted to a cow to a human? You know, there's all sorts of considerations that have to be discussed. And I won't say that our discussions came up with many answers. I think we ended each session with more questions than we started with. But they're important questions, and I look forward to seeing the draft that SIDRAP produced, and I think it will be a valuable document to guide us should a transmission or a suspected transmission occur.
Has there ever been a case of scrapie from sheep being transmitted to humans?
Not to our knowledge. And that's something that is often brought up by the hunting industry that equates chronic wasting disease to scrapie in many ways. And so we hope that the similarity is true for that as well. We've known about scrapie for hundreds of years, and there doesn't seem to be evidence that it transmits.
Thank you.
Yep. Going once, going twice. Oh, got 2 hands.
Hi. Is there any information on what percentage of people exposed to BSE in the UK develop prion disease later?
That's a really interesting question. And I don't know if there's an official statistic. What I can say is that there were believed to be millions and millions of people in the UK that consumed BSE contaminated beef. And the total number of cases, I mentioned 233 worldwide, I believe it was 178 cases in the UK. So millions and millions to 178. And that's one reason why when we look at chronic wasting disease, there simply may not have been enough exposures yet to translate into a human case. And so as it spreads to new areas, our concern grows because we have more and more exposures. Joe Abrams, who is here, I know has evaluated some of those statistics about numbers of cases of BSE. He's over there if you want to speak with him later regarding the exact numbers. I don't know if he can provide exact numbers, but more specific statistics involving the UK situation. And Simon Mead, of course, is very close to that data as well. Thank you.
This is hypothetical, again with CWD. When you mention about venison from a positive animal and then those that have, you can go back and check with them if they ate it, what about the processing plant?
Yes, very good question, and something we're still trying to grapple with. Processing plants are an interesting problem because hunters may take their animal, have it tested, give it to a processing plant, and they get a different animal back. So they say, oh, good news, I had a negative test, and then they get someone else's positive animal back from the processor. Or vice versa, they have a positive test, and something else. It could contaminate the processor. So there's certainly considerations around that. That's why our gold standard of our gold standard, if I look at the Wisconsin study as a gold standard, within that we pay even more attention to hunters that self-processed their own deer and consumed it, because we have that direct line of exposure and testing where it didn't change hands and potentially get switched. We are hoping that we can get more information on specific processors in Wisconsin, what their practices are, so we can refine the study a little bit accordingly. But it is a problem that we're aware of, unfortunately. Thank you. And just to backtrack real quick, I mentioned Simon Mead. Also, of course, Richard Knight is here from the UK, and he would have more information on the BSE story as well. Yes.
Hi there. Thank you for presenting. My question is, I know that in your slideshow you had mentioned that some of the cases are from like the workplace. So I take it people who work in the lab setting with CJD samples. So I guess how are they like more exposed to it? I'm like, if they're not ingesting it, and like what extra precautions should they be taking?
Yes, thank you. These were cases of variant CJD, and they occurred in laboratory settings. The details are a little bit blurry. I think there were 3 cases, and I know at least one of those was a needle stick. So it was an ingestion situation, but I mentioned that variant CJD can be transmitted through the blood, and that's been documented in a few circumstances. So a needle stick is bad news if you are dealing with specimens from either bovine spongiform encephalopathy or variant CJD. And in both of these labs, or the involved labs, we're using, again, BSE or VCJD specimens, and unfortunately lapses occurred.
David, or
Hi.
Brian. I know one of the one that we know the most details about is the French case, right? Where that was kind of a special scenario in which someone was working with BSE adapted animals that were super expressors. And so, largely I think these occupational exposures, again, a lot of the details are missing. But that one I think is very clear, and that was a very special scenario. It still is the recommendation from CDC and everyone else that clinical care is just universal precautions, right? So there's no risk at doing routine care on patients with CJD, of course, family members as well. So just want to make sure that assuage people's fears with that.
Thank you for pointing that out, Brian. Yes. Yeah, when I say occupational exposure, yes, it is not in the clinical setting. It was a laboratory, direct contact with infected specimens and the needle stick or something along those lines, yes.
Hi. I noticed on the slide the guidance for body disposal. Sorry, I don't know what term to use. It listed that cremation is fine, embalming is fine, and burial within a sealed casket is okay. Does that mean there is an issue with burial without a casket for like a natural burial? Is that not recommended or illegal or something?
I don't think it would be illegal. I don't know about how common that was when those guidelines were created. I can say that with animals that die of prion disease, for example, chronic wasting disease, landfills are used. I can say that with BSE, they had their own ways of taking care of the bodies of millions of cattle. So I'm not as concerned, but I don't think it would be advised. There may be someone in the room that can speak to more specific guidance on that, but Sealed caskets would be the preference. Yeah.
Back to the study and the news article with the 2 hunters who tested positive for sporadic CJD. I remember seeing that at the time and realizing that it had identified that autopsies had been completed and it was determined to be sporadic. Would that not have been the point at which that ceased to be of public interest? Because would not those tests come back variant, or are they suggesting that perhaps these are emerging sporadic cases from consumption? At the time, I remember thinking, like, this is a non-starter.
One thing we unfortunately do not know is what chronic wasting disease would look like in a human. So it could very well mimic a sporadic CJD case. And so we hope that, like variant CJD, the brain tissue analyses are going to be different somehow, that we can look at it and say, well, clearly this is something else going on. However, if we do see a sporadic case and there is a history of exposure and maybe other things going on, for example, maybe a particularly young age, these are things that we have to pay attention to simply because we don't know exactly what it might look like.
Not really a question, but a comment. About 3 questions ago, you were asked about controls for handling variant CJD. So as a lab actually that's using variant CJD in London, we have very, very stringent controls, absolutely no sharps, really, really minimized, containment level 3 containment, and everyone has to be really, really well trained and signed off. And so just to be very, very careful.
Yes.
And then only actually 1 or 2 people are allowed to handle sharps in there, which includes the director. So he's very well trained.
Very good. And I appreciate that comment. And in fact, in France, they shut down all Prion labs for a period of time as a result of one of these incidents to take a look at measures just like what you're describing and how they could be better implemented to be as safe as possible. So thank you for your comment. All right. Thank you.